So I'm gonna share some extraction hacks, some tips and some tricks. I know we all have to deal with extractions, and I've got 11 months. I take that back, 10 months and 1 day left in practice. So I'm getting ready to retire. And after a busy day like yesterday, I can be exhausted. And that's knowing these tricks and having the right instruments and keeping them sharpened. So when we have the right methods, it's really important that we utilize the best tips we can so we can make things easier on us and better for our patients. So just briefly, when do we extract teeth? We make decisions, and that's first of all based on the tooth. It's a strategic teeth, the big eight, the canines and the carnasal teeth. What disease do we have? Do we have periodontal disease to where we have a lot of bone loss? Or do we have a broken tooth with exposed pulp? Or a non-vital tooth that's dark and dead? So there's a lot of reasons to extract, but we always keep in mind our patient as well. If we have a patient with systemic issues, say I had a cardiac patient just the other day that we were evaluating, and instead of doing a root canal on that pulpitis tooth, we're going to extract it to remove that source of chronic inflammation that we see. I don't even talk so much about infection anymore, but it's a chronic inflammation that I found out can impact everything, including aging. And then certainly extraction, it's going to depend on the client. I think good interaction with them, good education. Sometimes I'll do some fancy periodontal work to save an important tooth, but I need to have good home care. I need them to come back on a regular basis. Sometimes it's just better to extract. So we have to have that client that's willing to go for it, to really do a bunch to help us save those teeth. I mean, I can save all the teeth in a jar. I can save the tooth and send it home with a client, but sometimes it's just better to get it extracted. We do have those clients who are amazing, who will do anything they want. That's why we have the picture of the unicorn here. They'll comply with all the medication, with all the home care. They won't complain about the cost. Their patients are great. They're amazing, but they're rather elusive. Too often we get the ones that we call narwhals. Yeah, they're the unicorns of the sea, and they've got that pointy horn still, but they're not quite as much fun to work with. But that's okay. It's the pets that we're impacting. So to start out with, if you don't have the right tools, you're going to be frustrated. And you might know some of these burrs. You might be very familiar. Here's just some of my preferences. So I do like the crosscut fissure burrs. 700L or even 701L on dogs. And the L shows that we might have a longer cutting blade. I might even use surgical length burrs. If you look down at the picture below, the 701, the 4, and the 2 have a longer shaft. So I can get to teeth in the back of the mouth more readily. However, you got to remember the water flow is not directed to that burr. So you have to be a little bit careful. Now in cats, if I was to use that 701 on the far left, I wouldn't have a premolar left if I sectioned a two-rooted tooth. So I like, second from the right, the 699, a little bit smaller. And this can help me section that tooth without losing most of the crown. The 2 round burrs you can use for alveoloplasty, whether we're making a ditch around that canine tooth or removing some of the buccal bone, or even maybe with a smaller round burr, ditching around a tooth root. I will also use diamond burrs, not pictured here, football or round or the typical shapes there, that allow us to provide a much smoother surface once we've extracted the tooth and getting ready to close. Now, I did slip in here a 12 fluted burr on the far right. I'll use those for a little gingivoplasty. If I've got a little taller gingival margin and not too bad on the pocket depth, sometimes I can make it healthier right away, or certainly when I'm doing gingivoplasty or gingivectomy on certain dogs. In order to get to that tooth to section it, I have to be able to do a good gingival flap. And this is where the periosteal elevators come in mind. I like the flatter ones. This is the 2 ends of a molt number 2, molt number 4, which is a real typical one, to be honest with you. I like them flat. There's some that are curved and some people prefer those. I kind of like these flat ones, and I'll tell you later on a secret about them too. I also have serrated versions that I'll use for debridement of soft tissue. Now we're going to talk about dental elevators and a little bit beyond that. I'm sure everybody has their winged elevator set, but we probably don't use luxators as much, all right? So there's a couple differences. Now, you can have flat and winged luxators, you can have flat and winged elevators. But when we look at all of these, we need to have a sharp edge to the working head. And we're going to choose a side that is really going to fit that root. As we look at these, we're going to be using them to help break down the periodontal ligament, to help fatigue the periodontal ligament as well. It is important with these instruments to keep them sharpened. I prefer sharpening the inside of the working end, shown here just by rounding off the corner of a flat Arkansas stone. Some people like to sharpen the outer edge of it. There's some preferences and some reasons for doing so. My biggest reason is I'm not terribly coordinated. It's the best way for me to do it. The key is the tip of this elevator or luxator needs to fit in the periodontal ligament space for optimal use. And this is a very thin space. So we need to keep these sharpened at the tip. And remember, as after every use, we might have to resharpen them. Eventually, because some metal is removed with each sharpening, you might have to replace these, but not everything is forever, even though veterinarians like to use tools forever. We're also going to look at some surgical type, oral surgery type instruments. The extraction forceps, I only use a small breed extraction forceps. I should not need a lot of force to remove that tooth once I've loosened it up. I like the 15C scalpel blade and either a regular scalpel blade handle or a cylindrical handle that allows a little bit better movement. My suture, I prefer the monofilament, the PGCL polyglycaprone. And I will typically say 4/0 to 5/0. 5/0 for cats, maybe on a tapered needle because their tissue is much thinner, but certainly on that 4/0 for dogs, a reverse cutting needle, absolutely needed for the thick gingiva. I've started using some 3/0 monofilament on some of my bigger dogs, especially the mandibular canine extractions. I really think 4/0 is getting thinner. I don't think it's just because I'm getting older. I'm just not as fond of the strength anymore. So I will reach for 3/0 at times. Certainly, we know that pain management is imperative perioperatively. We're going to be starting it before the pain starts, even the day or two before, and certainly in our preoperative medications. We're going to be using whatever agent is appropriate for that patient. Remember, even with opioids and different medications that work with pain, they do nothing for inflammation. So I still like that non-steroidal, all right? Because inflammation is a part of the process. The alpha-2 agonist as a pre-op can be used certainly, and we're absolutely going to be doing some local and regional anesthetic blocks. Certainly sending home pain medication as well to make sure they're comfortable in the post-op period. Just took a couple teeth out of my own older cat yesterday, and he is so happy on his Zorbium today. I tell you what, he's a very happy cat. So with the regional and local blocks, I tend to prefer bupivacaine. I do not mix it with lidocaine. While lidocaine is maybe a little bit quicker, it actually shortens the duration if you mix it half and half. All right, so I'll just get my blocks in early. At times, if I can find it, I like the pre-mix with 1 to 200,000 epinephrine, especially if I'm doing a lot of gingival surgery, but it's sometimes hard to find. That's okay. Regular Marcaine, bupivacaine is okay. I do cap it at 1 mg per kg on cats. I'm okay with 2 mgs per kg on dogs, but that's not a whole lot if you've got a small cat and they're stomatitis, right? You got to really measure that out. Now, I will use the liposomal bupivacaine, the Nocita, and I use it in a same volume amount. It's a little challenging with the way that they have their mgs per kg on that. So I do watch with volume amount. I do the same volume amount. I've said that 3 times now. I think you get it. I will at times use a small dose of buprenorphine with my bupivacaine, and there's different variations there. I tend to use 1/10 buprenorphine with 9/10 of bupivacaine, but I do watch the total dose. As we're looking at our intraorbital blocks, you're probably really familiar with the infraorbital block, the caudal mandibular block, or the inferior alveolar block. Look at the picture on the lower right side where we try to get our block as close to the bone as possible for that caudal mandibular canal. Mental block, first off, I like the name. If it's a larger dog and I'm extracting incisors or maybe the canine tooth, and I'm able to easily enter this middle mental foramen and inject material without any kind of stress, so it's easy to inject, I'm satisfied with that on the canine tooth. Studies have shown it can be variable, but I think I've had some pretty good luck with it. But just make sure you have good training. Now, I don't use infraorbital block as much anymore, hardly ever. We're supposed to go at the opening that's around the third premolar, not present in either of these skulls, but no further than medial canthus, which is a big difference in brachiocephalic in cats. So I look at a maxillary block from a caudal approach, and instead of coming straight up in a dorsal movement behind the molars, I will actually come with my needle and syringe parallel to the palate and come in from behind. My apologies, I thought I had an arrow here. I'll come in from behind and I'll keep it parallel to the palate to get to that caudal aspect of the infraorbital. WSAVA, the World Small Animal Veterinary Association, has some good videos about that. If you can't safely perform a deeper regional block, say you start to do the block and you get back arterial blood, or you definitely don't want to put it in a vessel, at least infiltrative line of agent in the buccal mucosa above the site you're going to be working with. And sometimes I'll do this if I'm just doing a little periodontal work too, because root planing and things like that, it can be uncomfortable. If you're extracting, then once you've raised the flap, you can even infiltrate some more on the bone, or if the bone's exposed, but at least get it blocked. We also know that radiographs, imperative. If you don't have radiographs and you can't get radiographs ahead, before and after, you're liable to have issues. The biggest part I look at these preoperative radiographs is periodontal ligament space, which is absolutely horrible in these feline mandibular teeth. I can see maybe on the regular 409 on the distal root, a little bit of root, maybe a little bit on the, 408 as well, but there's a supernumerary tooth in there as well. But I want to see, do I have a good periodontal ligament that will fatigue when I get ready to elevate? Or is there tooth resorption? Do we have ankylosis? Do we have a thin mandibular bone on a small dog? All these things are going to tell us and help us with our approach. And as we start that approach, it's going to be systematic. Don't skip steps. We're going to do a gingival flap with release. Sometimes an envelope flap will be enough. We're going to maybe take out a little bit of bone to expose that root better, like in a canine tooth, or certainly the furcation, so we can section the tooth. We're going to do elevation that is directed and controlled. And then we're going to finish the site, curette, possibly pack it, and suture that flap closed. So in initiating the gingival flap, like I say, I like that 15C blade. I like to make a cut on the gingival edge before I start elevating anything. And you can see in this top picture, the line where I have basically outlined about 1 millimeter or 2 of that gingival margin. I can cut it easily with the soft tissue against tooth, and then it's easier to trim it once it's elevated. I will also take my blade. I've got 2 pictures here, but I actually point a little bit down so I can start that incising the periodontal ligament, getting that gingiva off the bone, so it'll make it easier to release. I definitely, in my major teeth, like to make releasing incisions. Often I will do it mesial, such in this canine on the lower picture, and distal, so I can get good exposure of the tooth to facilitate my extraction. I need to go past the mucogingival junction so I can help release this flap. So again, good exposure, release of tension so I can close it well. I do know there's some diplomates who state that they can extract all teeth with just envelope flaps. All power to them. I like to see what I'm working with. Especially with these dog canine teeth. The roots are larger than the crown. That's why I like these two releasing incisions on this maxillary canine tooth. I might be able to get by with just one mesial incision on the upper fourth premolar because it's somewhat triangular shaped anyway. And this mesial corner, once I've elevated and released that flap, will just rotate and go right into that palatal root space once I've got it extracted. But I want good access for these canines. Now, I do know some colleagues are comfortable with doing just an L-shaped flap with one mesial incision and then elevating back to about the second premolar. But as we look at those in particular, we have to look at how much is happening. All right. And supposedly we have an echo on the line, but I think she's taking care of that. Now, before I go to this one, real quick, as we're making these releasing incisions, I take the tip of my blade and I make sure I really dig down into this corner right here and make sure I get through full thickness of the soft tissue, because that's usually where it's going to hang up if you didn't cut through it completely. It can be quite thick right there. So once I've got those incisions made, I'm going to take my periosteal elevator. In fact, my fingertip is going to be right on top of that blade. I moved it aside to get the image, but I want good control of this instrument. It's going to be just past my fingertip. I'm going to do a full mucoperiosteal elevation, elevating that attached gingiva with a periosteum underneath coming up with a flap and extending past that mucogingival line a few millimeters to where I'm getting into the buccal mucosa. Yes, you can elevate all the way up to the apex of the root and you'll have great exposure at that point. Anytime you lift gingiva off bone, it can actually decrease a little bit of the thickness of that bone. So I usually elevate as far as I think I need, at least to the wide part of the root on these canine teeth. And if I need to elevate later, I can elevate more later. Releasing the flap can be done at the end of the procedure. I kind of like to work on it right now. And while you might be able to tell us that some of our other pictures have been actual patients, this is a specimen for demonstration. So when we're looking at this release, as we lift the flap, there is a continuous layer of the periosteum on the underside of this flap. And if we don't snip through it, then we won't be able to pull the flap over the defect. It'll just go back right into the position that it was. So we lift it up. I like using scissors. Some people like using blades. And then I snip through this periosteum so I can separate it. And now I'll release the tension when I get ready to close the flap. I've got a few slides focused on the mandibular canine because this is probably one of our more challenging extractions. And I've developed kind of my own approach to this. I know other people do it like this. Some people actually go with a lingual approach because the bone on the lingual side of the canine is thinner than the buccal bone of the canine. All right. What I focus on is where this tooth root is going in a lingual kind of direction in the mandibular bone. So I like to do a really good release at the distal aspect. So I will make a cut almost falling to where the premolar is with a little bit of a cut on the mesial aspect, on the lingual aspect, a little bit of cut on the distal aspect. Now, as I'm making these cuts, I'm actually going to remove a small triangular piece of soft tissue here that I'm probably going to be trimming off anyway because you have two L-shaped flaps here. So I take that out anyway so I can get better exposure. There are some canines I'm able to make just these cuts and get enough exposure to start elevating. But to get better exposure, I'm going to make this buccal cut at the distal aspect, and I'm going to make a buccal cut at the mesial aspect to expose the buccal aspect of this bone, okay? But I'm also going to really be focusing on trying to access the root as it goes distally into the mandible. So here showing that buccal flap and here showing the lingual flap. In fact, on this lingual flap, I might even make my cut behind this triangular piece of tissue called the frenulum to get a little bit better exposure. As long as I can get to the distal aspect and I can see the buccal bone, the lingual bone, and the distal bone. And we'll talk about how we work with that bone in just a bit. Because these canine teeth, especially on dogs, is generally wider in the root than it is at the crown, I need to make an opening that's just as wide as the widest part of the root. So that typically means I'm going to make a groove at the mesial aspect, the front aspect of the tooth, and a groove following the distal aspect. I will usually shave off this bone to make sure that I'm really past or at the periodontal ligament space. I've seen people that have made the grooves, but they're cutting into the tooth itself. But we want to have good exposure of the root at the widest. And when we remove this buccal bone, we're able to even elevate the bone from the tooth on the flat surface of the buccal side of the tooth. Again, I will remove several millimeters initially. And if the tooth isn't loosening up, then I might need to remove more bone. Particularly with maxillary teeth, while I don't like to do it every time, if I need to remove the bone to the apex, I can generally do it fairly safely. We don't have as much bone structure with the mandible, so we have to be a little bit more cautious there. So a couple hints with the mandibular canine for better access is I will cut off the top third of the crown, because remember, it kind of curves up. I want to have a straight line access to the distal aspect of this root. And I will take off, as shown on the skull, a little bit of lingual bone, a little bit of buccal bone, and a little bit of distal bone. Now we're going to have an opening that's at least as wide as that canine tooth. And it's a little bit wider from front to back, from mesial to distal. Actually gets kind of thin as you get further down the root, but still wide in that direction. So when I'm looking at accessing this tooth, I want to do my flaps. I want to take off a bit of the crown so I have better access. That way I'll have less troubles with that tooth. Another place we'll remove bone is with any multi-rooted teeth. And I could even take out a little bit more on this mandibular first molar, but I want to see where the furcation is. You might have periodontal bone loss to where the furcation is already exposed. That's great. But what I need to do now is after I remove that bone with the round burr or something like that, then I'm going to be sectioning the tooth. So I need to see that furcation. Here I'm a little bit more conservative because, well, this is a bigger dog. On our smaller dogs and cats, the cortical bone is the buccal bone plate and the lingual bone plate. That's the strength of the jaw. We don't want to remove too much of that on the mandible, right? But I can take off as much of that buccal bone as I need on the maxilla. On the mandible, if we're having issues with elevation or in root tips, once I can get access, I may take out the bone that was in between roots, that interseptal bone. That's not as much part of the strength of the jaw, but it will allow us better access to the roots. So on these lower first molars, I like to do two cuts. Once I've got my elevation, in fact, I'm taking out multiple teeth here, so we've got a fairly wide flap. And you can see that I've sectioned 408, but with 409, could have taken out a little bit more bone for demonstration purposes, but I want to cut from the furcation back to the developmental groove from the space in between the cusps, and then from the furcation forward to remove this wedge-shaped piece of bone in between the roots. That will give me better access to both the roots, the mesial aspect of the distal root and the distal aspect of the mesial root. And if you notice, I've got a tongue depressor in here protecting my soft tissues. Do not use your periosteal elevator as a tissue holder. You'll end up damaging it. But definitely use that crosscut fissure burr, plenty of water, making sure it's getting to the burr itself, and then making your sectioning. Here are some of my hints for the maxillary fourth premolar. Remember, it's 3 roots. As I do my flap, again, I can see where the furcation is, or I can take out a little bit of more bone there. With a flat, using it nice and gentle, I'm going to be doing a cut from the furcation to the developmental groove distally. I'm going to use that burr and gently shave off the backside of the crown of that upper fourth premolar, not touching the upper first molar, but that will give me space to put my elevator because these teeth are usually crowded. Next, I'm going to come with my burr, and I'm going to come from the furcation, come mesial. And again, taking off a portion of that crown, a diamond-shaped piece, whatever you want to call it, a wedge of it. When that piece is removed, I can now see between the two mesial roots. If I were to make a cut over the cusp of the mesial root, I would not hit the furcation. Where you see the line about halfway in between that tooth, in fact, it's right below where the pulp, you'll notice the pulp, it's a little V shape. You cut from that part of the furcation to the V shape at the mesial aspect of the tooth and get far enough down that you completely separate those two roots. Once you start elevating, if it snaps off, and that's usually going to be that buccal mesial root, you might see where that band of tooth is still there, and you still have to cut through a little bit more to make it all the way through the furcation. So this is just one way I can get better idea of where my furcations are and how to separate them completely. Now, say I only have to extract the maxillary first molar and not even the second molar. I'll tell you what, though, if I can find a reason to extract both at the same time, it's going to help me develop my flap better. But just in case I just have to extract 09, I'm going to do an envelope flap from 108, covering 109. Boy, if I cover 209, that would be a really big flap. All right. Elevate the soft tissue around, section into 3 roots, and then elevate. Now, remember, even if it's really, really loose, still section this tooth. Even if you have to hold it still to section it, these can have some curvy little roots. And if you don't section it, you're going to break off one of those root tips, and they're not fun to find. Thing of it is, we've had a study now that shows us if we loosen up this mucosa, and it's it would have to be a very long flap, but if we loosen it up, I like to make sure I get one good suture behind the upper fourth premolar, okay? Because that's the tooth I'm keeping. That's the tooth I want to stay healthy. But then I just do a cruciate across that gap. And studies have shown that the blood clot there is going to be sufficient to allow that to heal. For our initial elevation, this is where I'm going to start talking about luxators. Luxators are flatter. They're thinner. They're actually more delicate. If you will excuse me just a half a minute, I just heard my Roomba come on and I don't want her coming in the room. I'm so sorry. I'll be right back. It's hard to get good help these days. She was supposed to finish before noon. So anyway, a luxator, a periotome, a pisotome, they are meant to go directly in an apical direction down the root to sever the periodontal ligament. All right. So we definitely need these sharpened on a regular basis. These are a little bit thinner. And when we put it down that periodontal ligament space, we are never going to twist it. It's just a straight down into the apical direction. We might be able to rotate it, swing it a little bit like that, but no rotation. Sometimes we're going to have simple elevation, a single rooted tooth, maybe a loose canine on an older cat, and then we're just going to move it back and forth, gently remove it. Sometimes we don't even need to take out any bone or whatnot. We can just put a suture. To me, that could be an extraction. Anything else that has to cut tissue, start calling them oral surgeries, okay? Because we're cutting tissue. We're doing surgery. And in fact, when we start looking at some of these bigger teeth, it's a lot of oral surgery, right? The key is trying to be deliberate, trying to be patient and controlled, trying not to get distracted. I think that's probably when I break off all the roots I do. I get in a hurry. I get impatient. I really think I've done enough elevating, so I grab those forceps and crack. Now I've just extended the time I have that patient under anesthesia. So be deliberate, be patient, control your elevator. Make sure your instruments, like I said, are just a millimeter or two past your fingertip, especially when you're going in an apical direction. At that point, if it's introduced into the periodontal ligament space, you might be able to back off a little bit to do slight rotation, sit and hold, but be very careful with that sharpened blade as you're going apically. You don't want a big oops. You don't want a little oops, but you definitely don't want a big oops. So yes, we can go between teeth, we can go between tooth segments, but it's really the most efficient work is when we can get that winged elevator cupped down into that periodontal ligament space and then do our rotation. Because if we do try to elevate in between crowns or in between a tooth and an adjacent tooth, the fulcrum of the force is now beneath the bone line, and the possibility of fracturing those teeth are definitely increased. And if you're holding it far back on the handle and you're going with forward motion, that oops, there is the mandibular maxillary teeth. You have the infraorbital canal right between those upper four premolars. The orbital area is very close, especially in some patients, cats, brachycephalic, and small dogs. And yes, eyeballs have been hit, even brain cavity has been hit before. So we want to be very careful with our efforts. Now here I'm going to show a couple things with that mandibular canine. This is actually a periotome. I can tell because it has little jagged edges to it, but very flat, very thin. While our winged elevators work great on the curved surfaces of teeth, we can't get them all the time to help release those flatter surfaces. So my periotome, my luxators that I can get into an apical direction and then I'll wiggle them back and forth, no rotation. That can help me separate that tooth from the bone and sometimes even advance a little further apically, separate a little bit more, make sure it's separated on the full lingual aspect and buccal aspect. And then I'll also work on the curved aspects, the mesial and distal aspect. Here's using a winged elevator. Actually, this is a wing lux, so it's a winged luxator. And you see how I can follow the length of the distal part of this root when I take off that portion of the canine crown. All right. And again, when I first put it in, of course, my finger's right there on the tip. But once I've got it in here, now I can do rotation, sit and hold, rotation, sit, hold, fatigue that ligament. Anytime I'm in this area, but especially when I'm at the mesial aspect in between the canine tooth and with the incisors, remember your furcations there. Always check for a furcation mobility before you start. Sometimes it's there before you start. But I really grasp and hold the jaw with my opposite hand and I almost like hold it together as I'm doing any kind of forces. All right. So using the combination of these instruments, using sharpened instruments that fit the spaces right can be so, so important. And having it is good. So someone said how to best close upper M1 as the tooth is almost square. Remember, we've been told that a study was done that a good cruciate, I mean, loosen up all the gingival margins, but a good cruciate helps. But these lower canine teeth are the bane of our existence some days. And you have to be able to provide the forces that will elevate the tooth without breaking the jaw, right? I think that's some of our most common extraction referrals. Once I start seeing some motion with that tooth, I start seeing the bleeding in between the tooth and the bone, that periodontal ligament is starting to give. Then I'll gently grasp with my extraction forceps and do the same. Sit and rotate a little bit, not a lot. Especially on maxillary teeth, I don't want to rotate roots up into the nasal cavity. But not only will this continue fatiguing the ligament, it will tell me where it's not giving, okay? Sometimes I can start elevating it and I can see that's elevating well, maybe on this particular tooth, on the mesial aspect and some on the distal aspect, but we're not getting any movement or bleeding on this buccal surface. Well, then I need to get my flatter elevators in there and elevate a little bit more. I'm going to go back to the last one. If you don't currently have flat elevators, if you have those flatter periosteal elevators, now don't tell anybody I told you this, but those flat periosteal elevators can sometimes be gently introduced into this periodontal ligament space in between tooth and bone and windshield washered a little bit to help separate out that just a tad. Okay, I'm trying to answer the questions as they come up so we have pretty good information. Any tips on extracting 310 in a small dog? I'll do that at the end. Yeah, sometimes those are tough to get to. So if I'm doing this rotation, maxillary canines, if they have curvy roots, don't cause an oronasal fistula, okay? But it can really help you see where you need to take out more bone or elevate more. So if you need to take out more buccal bone, especially on the maxilla, all right? I will try to do a little bit more elevation, probably with a little bit smaller winged elevator on this tooth, but I'll go work more on the distal aspect and the mesial aspect. Sometimes we already have an oronasal fistula here. And then I'll definitely make sure with my flatter luxator that I am separated from the buccal bone, okay? So patience, gentle touch. Once we've got that fully elevated, now we need to prepare the flap for adequate closure. And I keep in this old slide because I want to point out one thing. For this particular slide set, and it was, again, as you're looking at it, we have a large mouth gag with a spring, and we don't use spring mouth gags anymore, ever. So get rid of them. I'll use spiral perm rollers from Sally's Beauty Supply as a soft mouth gag, but just please be careful with that. So after the tooth is out, I'm going to make sure I elevate the lingual and palatal aspect of the gingiva. All right. That way, when I get ready to take my bites with suturing, I don't have to fight against bone. And it also helps me isolate the bone so I can smooth off any rough surfaces. The alveoloplasty is important in every extraction site, but so important with our like stomatitis cats. I'm very aggressive on my alveoloplasty with my diamond burr, making sure everything's really, really smooth. Now, there are some places I may put some bone implant material, osteopromotive or whatnot. It varies. I don't need it in every site. It depends on how much strength is left there. And the different products have different capabilities. So just be aware, it's not apples to apples. When I get ready to suture, because I've elevated that flap, because I've snipped through the periosteum and I've elevated my lingual mucosa, I'm going to be able to suture without tension. And for the most part, I'm doing a lot of simple interrupted. I will tell you definitely on my mandibular canines, while I typically use 4/0 in most cases, I will switch to 3/0 on these dogs. The only problem I've had with dehiscence has been in big dogs, lower canine extractions. So I use a little bit larger suture. I try to make sure I have not cut through the frenulum here, but what I'll also do is you might be able to see the vertical lines back here, kind of tucked in here, that I'm bringing out through the lip and putting in a supporting mattress suture at that site. The upper canine usually doesn't mess with this too much. This suture is usually lost within a week or two, but it helps support that. And if you have any kind of chewer, any dog that's going to really mess with it, put them in the cone. Really protect these sites. It's going to be one area that can be a problem. Now, I've already mentioned feline stomatitis cats, how I do a really aggressive alveoloplasty. The other thing I do for them is I will do cruciates from the caudal aspect forward with a buried knot. Now, burying these knots, it takes a little bit of different mindset, but you're going to do cruciates. Instead of coming from the external in, you're going to come from the inside out for your initial loop. You're then going to come from the outside in. And next time I do this, I will wear gloves so you can't see my dry fingers. But that's the first pass there, your first loop. And kind of typical, you always get it stuck around a canine tooth or something, don't you? Make sure you keep your tail forward and visible. even a little bit longer so it doesn't pull through. And then do your second portion of the cruciate. In to out, out to in. And when you get ready, even right now, you can see that just bring these suture lines in. We have buried the knot behind it. And when we get ready to suture this, the knot will be underneath, and the subsequent cruciate will bury that knot. Now, for that healing patient, I don't have any exposed knots. I can collect plaque and food, and I've had some really good luck with it. All right. So celebrate success. These little plastic cats aren't just for neuters anymore. We even made a little tray for this one so they can hold their canine teeth that we've gotten out successfully. And it's a good feeling when they come out. I'll tell you what, especially if it's been a tough day and you have a lot of work going on. So celebrate. Now I want to kind of talk about some adding on to extractions. So I talk about starting with the end in mind, not to quote Franklin Covey, but hey, it's what it is. When I'm looking at teeth that need to be extracted adjacent to important teeth, lower canines, lower first molars, even upper canines, I really think about how I'm going to manage the soft tissues to maximize the health of the tooth that is remaining. And this is a common sight here, even distal to this 409. As we look at these, I'm going to be doing flaps to enhance the periodontal health of the tissue that will remain. So when I make my cut, I'm going to come in front of 408, and I'm actually going to be doing what's called a reverse bevel, getting my blade inside this tissue, so I end up removing some of that internally diseased tissue. What I want to end up with is a good collar of attached gingiva that's going to close around the front aspect of this tooth. So I will make my releasing incision mesial to 408. I will come in, and in fact, I can trim it later, but I'll actually try to trim it and make sure that any of this tissue that's inside, especially where this attachment loss is, where this pocket and diseased tissue is, I'm going to end up debriding that, as well as taking out 408 that, you know, it might be a stage periodontal 3 plus, not even 4, but by extracting this tooth that is crowded with 409, I'm going to make 409 healthier. And that is going to be a big difference with some of these teeth, especially the 09s and the 04s on the lower, and even some issues with maxillary teeth as well. So with that tooth out, I now have access. Look at all that calculus that would have remained. Look at that pocket that's there. We have a little bit of an infrabony pocket. I need to do a thorough debridement, root planing, cleaning within that pocket. But I also kind of left a root. So I'm going to be ditching out this area on this distal root to identify it and remove it completely. Unfortunately, when I did that, it was really kind of close to the mandibular canal. So I had some extensive bleeding, but I still needed to get that root out. So that's where I applied the Vetagel. And I've had fun using this because I can apply it. I can go work on something else. I can even do a little root plating on this tooth, but usually you have more than one spot you're working with in a mouth. I used it the other day on a tumor removal where there was an active bleeder from the bone. And I was able to put that in there and help with this bleeding. Now, in this particular case, one reason that it really worked well for me is I waited until the hemorrhage had stopped. Then I was able to remove the gel and get access to that root. All right, able to get the root out, able to finish cleaning. And when I go ahead and get any bone product material, if I have os or allograft or something like that, any sockets, sometimes even the periovive in there or the regum, then I can suture up. Now I have a much healthier situation with this lower first molar. Little cut in the gingiva here that allowed for some release. I now have root exposure. So I'm not going to build up any bone further up on this tooth, but I don't have a pocket anymore. So this area here is going to be easier to clean professionally, easier to keep clean with home care, and overall a healthier situation. So think about what you want to end up with. By taking out 408, I got better access to treat 409. and was able to stop some hemorrhage as well. This is extremely critical as well with our mandibular canines, because so often we'll have that pocket in between the canine tooth and the incisors, or maybe we've already lost those incisors. Now we have all this redundant tissue, but we have continuing pocket depth around those teeth. And these mandibular canines are very important to try to work with. So we talk about looking at doing root planing, about doing some cuts to open this access site. And there's something called a wedge resection that looks at cutting to the inside of this tissue. It's called internal bevel, to remove the diseased tissue, allow us access to extract the incisor, clean the canine, use bone graft material if necessary, and then when it's sutured further down on the tooth. Yes, we have root exposure, but a much healthier periodontal situation. And here we have it cleaned out. Now, again, like we do have more root exposure, but much easier to keep that canine tooth healthier. Just wiggling out those incisors isn't quite enough. I do know people who talk, oh, I'm doing pretty good on my extractions and everything else. Now I want to learn how to do root canals. Learn how to do a little bit more advanced periodontal procedures, and you can make a big difference with your pets. Now, briefly, we're going to talk about complications, because we don't have those sharpened instruments, or we get too anxious or rushed, or or 2 o'clock is already there and it's only 1:30. Then we can have those complications. When we do have root tips, then we need to open up the site. If this was one that was sent to us, I might need to take out some more bone. I can take out whatever bone I need on the maxillary surface, okay, buccal surface. But with my mandibular teeth, I might take out more bone around the tooth itself, ditching that, and then using smaller instruments such as root tip picks, or even my smaller luxators to help getting that out. We don't want to use a lot of apical force, else it might drop into the mandibular canal. We don't want to pulverize these out. Now, if this X-ray had showed me that there was odontoclastic or replacement or absorption of these roots, I wouldn't have to get them. But I can see every bit of this periodontal ligament, even though the bone's trying to grow over it. So I've got to get these roots out. So when I'm looking at these, especially with the mandible, I try to look down, and I might take a little bit of that bone from the lingual and buccal side from the inside, cupping it out, creating a ditch, but really working on the interseptal bone that was in between the roots. And then when I'm gently elevating those, I'll elevate more front to back versus a lot of apically position forces. Because yes, this has happened to me as well. If you have bone loss at the apical aspect of that root tip, once you loosen up that root tip, it may go right in the mandibular canal or into the nasal cavity. All right. Most times we know we got to get these out. It's easiest to retrieve the tooth tip at that time because it's already loose. So I'll just make my ditching a little bit wider, enlarge the hole it fell through, and flush with saline. 9 times out of 10 at your next x-ray, that will have flushed out. Okay, you don't even see it. Sometimes you can visualize it and you can get in there with some root tip pick forceps, but sometimes it's like bobbing for an apple and it just keeps going further. On this particular root, you could take out more bone that was in between the roots and make that opening a little bit wider. Be a little bit careful. We know the mandibular canal is right there with the vessels. As I did with my particular case, I did kind of hit it a little bit. All bleeding stops eventually. The Vetagel certainly helped with that. But then we were able to retrieve it and get it finished up. Now, with every case, we talked about our preoperative pain management. We are going to send home or apply postoperative pain management. In fact, we try to get the Zorbium on the kitty cats early in the day when we're doing their procedures. I like using combinations. I love the opioids for the pain, but I want the NSAIDs for the inflammation if we can do it. At home, they can do cool compresses. Even for later, gabapentin is not a standalone for pain, but for chronic pain, or if we anticipate any neuropathic pain, that can certainly be the way. But sometimes we want non-medical medicalized procedures as well. And that's where the Assisi loop, we thank Zomedica for sponsoring this today. I've really gotten fond of these loop products because as we look at this pulsed electromagnetic field, enhancing the nitric oxide production can help increase the blood flow for healing, but decrease inflammation, really impact some of those cytokines. And let's just say I've heard of certain people who've used it for their own tooth pain and knee pain and maybe even hangover pain. You did not hear me say that one. But there are studies in the human, lots of studies in the human field. We have studies in the veterinary field too, to show that it helps with pain and returns individuals to function more quickly with less opioids. Now, as we're looking at these products, they're made of coils, a round coil, and you get this barrel effect. And the area being treated needs to be within this barrel. We usually look at 15 minutes twice a day, and typically has an automatic shutoff after the 15-minute treatment. Here's a Weimaraner. We're holding it close to the face. It just needs to be held. There are specific bonnets that can be used to keep it in place. I forgot to tell an owner that she did not need to put it over the head of the cat. It was a good cat, I guess, but these can be very helpful as we look as adjuncts for treatment. And certainly with the dental loop itself that we saw in the previous picture, little less on the cost, about 60 treatments, gets us through full 30 days of postoperative. Not just postoperative though. Think about getting these for the owners, having them pick it up before the surgery, especially with inflammatory cases such as those stomatitis cats or dogs, having them started ahead of time, provide some of that anti-inflammatory and that analgesic effect, and then continue it throughout. In addition to other things for chronic pain management, we may be looking at those gabapentins, amantadines, acupuncture, but certainly, just like with the chronic osteoarthritic pains, these loops can be used for chronic oral pain as well. For those that need lots of help, the loop lounges provide full body treatment, multiple sites for osteoarthritis. I've used it on my kitty cat who has chronic pancreatitis, and can be extremely helpful for some of these uncomfortable patients. And I'm going to slip something in here. As we talk about trying to reduce inflammation, I mentioned inflammation over infection before. Inflammation actually impacts the rest of the body, impacts aging. So if we can impact that inflammation by getting rid of conditions in the mouth that may cause it, even if it's full mouth extractions, and then by using devices that can help decrease inflammation, we can have healthier patients, not just healthier mouths.